I'm ready.
Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd, my usual partner in crime over there, Dr. Brandon Cruz. Fresh off of our ACL course, we're going to be talking about something that came up during the course of are we progressing our ACLs maybe too fast, too soon, and what detrimental effects that could potentially have, or maybe are we underloading them? So it's left up to debate, but Brandon, how's it going?
Going well, man. Early podcast for us, so I'm drinking coffee this morning. I think you are as well.
Brewery cup, though. I got you.
Very nice. I know you're doing some mentoring actually away from your site. You're going to a neuro facility to teach and mentor manual therapy. Oh, look at that.
Yeah.
Blending worlds. Oh my God. Would have never thought those two would happen years ago, right?
Yeah.
So kudos to you. But yeah, even bigger kudos to you and shout out to Jeremy putting together and being the lead instructor on your first course, which is the mother of all ACL courses. Jeremy, you absolutely crushed it. I'm not just saying that because we're friends. I mean, that was a phenomenal course for anyone and everyone listening. If you guys see ACLs, if you want to become that go-to provider, this is the course. It is probably the most comprehensive, gives you everything you need to be, blends all worlds from prehab all the way to return to sport and performance afterwards, includes manual therapy. I mean, just really incorporates a lot. Pretty dense weekend.
Yeah.
So I'd say, if there's a flaw, that it was just a lot of information, but well put together, well constructed. So off that, obviously one of the main topics there was appropriate timelines and progressions for ACLs. And we got off on some bunny trails during the course. So we figured we might as well bring it to our audience here on the Nips and Sips podcast. And so that's where we are today, man.
Yeah. When I first created the course, I was like, it's so specialized. Maybe it should just be a 1-day course. And then like midway through creating, I was like, oh no. I was like, this has enough content for a 3-day course at this point. So two is definitely in the sweet spot. By the third one, you'd probably never want to see an ACL again. So we settled on 2. But there's definitely, this is a hot topic. Mostly, obviously it's because most of the individuals who undergo this are sports and active, and it's exciting, especially for like general outpatient places where it's like you only get a active individual once, maybe in the blue moon or a couple in the blue moon. So it's exciting to progress them and do some creative stuff versus the mundane. But I definitely think it's sometimes comes at the cost of the patient. As somebody, I guess we have a very good reputation and name, especially for the return to play component of things. So we get a lot of people that come to us after a couple months. So I would say, unfortunately, we've labeled them the sloppy we don't label it to their faces, but they're sloppy seconds, in a sense where hopefully none of them are listening to this. Nothing against you guys. We love you all the same. But we do get these individuals that are coming from other places, and they're having tough times, and that's what ultimately I guess leads them to us. And they're just like, oh well, I got cleared to run a month ago, but I'm still having pain running, or I'm doing some agility work and they still don't have the range of motion and their knee's still swelling up. So very, very frustrating, not only as a clinician, but how frustrating that must be for the patient as well. And it's mostly, I would say, they're more ego thing or wanting to do some cool stuff, and I don't know what the motivations behind it for the clinician, but I think it's something that needs to be put to rest, to be honest.
Yeah, I mean, I'll say this, looking back, and I had a huge obsession and passion with knees and ACLs, dating all the way back to undergrad. I mean, I partially tore my ACL as well, so maybe that was it. But for all you aspiring sports clinicians, and everybody wants to get in sports, it's some new buzz and sexy term, and you want to deal with athletes and stuff. It's cool because you could do like more fun stuff with them, right? And I was the same way, but as I've evolved in my career, like that's not where it's at. The importance is that beginning.
Yep.
Like you said, those beginning phases. I mean, those are that, that initial time. And if you think about anything, that's, think of babies, that crucial time's the beginning, right? I mean, they
Very
really
critical.
you really have to, make sure you're being detailed in the beginning to make those other things fun. But everybody wants to jump to squatting or jumping and running and agility stuff, right? It's cool and sexy, like you said. It's I guess a break from the mundane, but that mundane part, that's, keep it simple, stupid. We have to hit certain metrics, and I'll segue this, or I'll pass this off to you in a second. Like getting knee extension, getting that quad firing, making sure cyclops lesions don't, form. I know it's a big hot spot for you.
Mhm.
Checking regionally, right? Checking the ankle, assessing the back, seeing if there's any other underlying issues that could have caused the ACL, an ACL tear, things like that. Like we need to do a better job at zeroing in on these things and stop trying to rush our patients to squatting.
Yeah.
I mean, we have a bunch of social media accounts that just love exercise and squatting. Cool, that's a part of it. It's functional. Yes, we do need weight bearing for joints after surgery, but like you said, we can't come at a cost. So I'll pass it off to you on the importance of obtaining these beginning markers in our phases of rehab.
Yeah. I mean, I talk about this over the course. The ACL is probably of all orthopedics, is sixth most research thing, I think, from what I saw out there.
Yeah.
So there's been hundreds and hundreds, if not maybe thousands of
Probably
articles
thousands. Yeah.
researching the ACL, and whether it's Delaware Oslo group, Moon group, groups in Iran and Russia, I've seen they come to the same similar metrics of sorts, maybe off by 5-10%, but same things that they look at a ton of things and they realize these are the things that the ones that do extremely well have, and these are the things that the ones that retour, didn't return to pre-injury levels or competitive levels, they don't have those. So they start, there's trends, there's trends in everything. So it's super, super important. Getting symmetrical extension, I think, is the big thing. Of those, I'll take it back. Today will be the last day I say sloppy seconds. I'll put that to rest. But those, of all those, almost every single one of them don't have it. And especially the hyperextension, that is so commonly missed. And you can't, I mean, try it, do it while you're listening to the show. Try and fire up your quad, but bend your knee about 10 degrees and see how tight that feels. You just won't be able to. Yeah, I know there's the more mechanical advantages, within the 45, 90 degrees, but try and get a good symmetrical, good quad contraction at 10 degrees knee bend and see how well you do. And you got to think that's how you, with walking, we typically walk with a more straighter knee. We don't walk with knee bends. So that leads to, a sloppy kind of course of things. I've seen it where it's like you get it, or they may have gotten it once and didn't decide to maintain it. They're like, oh, we got it. Yeah, we got 1 day of full extension. All right, let's go ham.
It's good
And
enough. Right?
then
Yeah.
they start to lose it, right? Maybe they still have that passive posterior capsule tightness, or end range tightness, and it's like, no, we're good enough. And then all of a sudden they don't test that water, they don't push that full extension, and then all of a sudden it goes from they had it to this is a little bit more comfortable, this is a little bit, and then you're 3 weeks out, and then you do your measurements because it's a reeval, and you're like, shit, where'd that extension go? And then you now just lost 3 weeks of that beautiful window of 6 to 8 weeks, and now you have to, we have to work back on getting extension. I mean, think about how big of a nut shot that is. It's like something you celebrated, you got, because we usually celebrate and we're happy when our patients get full extension, and then you have to go back and get it. That's heartbreaking. I would think that's heartbreaking. I never had that.
How about the therapist? And I did this early in my career as well. It's like you passively crank on them and you get the goniometer and you have someone hold them down.
Oh
And,
yeah.
oh yeah, we got to 0. Great, we won. Like, no, you didn't, because they don't have that actively. Like you had to literally use 4 hands to get it to 0 and then called it a win, when it really wasn't, when they should probably have passive should be into hyperextension and they should be at 0 actively, is where they need to be. So I think, recalibrating our acceptance level of what 0 really is,
Yeah.
needs to really hone in as therapists.
And to top off of another thing he said, and something that I did when I was younger was like, oh, what we did is we cranked on him. Like, all right, I get it. I need to get the range of motion quick. Great.
Yeah.
You're at least one step ahead of a lot of therapists. But how you go about getting it becomes part of the issue. So we can go too hard, too fast on gaining range of motion. If you're going in and just going past the range of motion, which I did, it was just straight push down to extension, straight flexion, off you go. How aggravating that is to the joint, especially in the earlier stages, and how you can cause hemarthrosis of the joint. It starts to swell, and then you start losing range of motion. Like, this doesn't make sense. I'm working hard and getting more range of motion on the table, but they're losing range of motion. Well, it's because you're going too hard, too fast. What else are you doing to maybe build up a range of motion at a steady pace, like graded exposure? We talk about graded exposure in exercises and function. Why not range of motion? Instead of murdering them on week 1, week 2, causing them to blow up the joint, causing them to be psychologically traumatized about any time they get on the table and they're near you. Why can't we figure out some strategies to, like, all right, here's 10 degrees, here's 10 degrees, here's 10 degrees, and the joint's not blowing up. So I see that a lot. Is like, yeah, they crushed my knee like the first couple weeks, and then they stopped touching me, and now they come in and they only have 80% of their range total. So that's something that, I know I used to do it. It was just like, all right, I gotta get range of motion. Let's blow this sucker up. Well, I didn't think that.
No, something you said during the course which really resonated with me, or stood out, is you're talking about extension, but same thing with flexion, and putting people on the bike too soon and thinking the bike is going to get them that flexion. And again, you're pushing it too hard, you're going to cause hemiarthrosis of the joint. It's going to cause it to swell. That joint's going to piss off. They probably are compensating at the lumbopelvic region, kind of hip hiking to get that knee joint. Doing half revolutions or quarter revolutions is one thing, but not forcing that full revolution early on. And you mentioned doing a like an active assistive on the rower, which is great. So you it's like the flexionator, but you don't have to spend however much crappy money there is on a flexionator, right? Using a C2 erg, put the one foot in and use the other foot to allow them to straighten and bend the knee. So I think that was just something that really stood out to my mind, because I think too quickly, and I've done it, we put them on the bike and we think, oh yeah, we're just cranking into flexion and it's safe and it's okay, they need it. But making sure they have, probably 95 or 100 degrees passive range of motion first, and not just 90, close enough, can get you on there, because you probably need a little bit more. And I think doing reverse pedaling versus forward pedaling is a way to regress that as well. And slowly grade that patient on into going forward. So that was just something that stood out to me.
Yeah, I mean, I know I always take videos of it and that sort of stuff for first revolution on the bike. Another exciting moment in physical therapy. But again, it came at a cost of a couple people, especially if you're in places where you see a lot of them and they start to see other people on the bike, and then they wonder why they can't, and then they muscle through it. And then again, they blow up their knee in a sense. Really say like what's safe and that sort of stuff. Extension is very, 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 I don't think I've ever had too many negative consequences for trying to get, extension ASAP. But flexion, whether you're, especially when you're thinking of how the ACL winds up in more flexion, that sort of stuff, the more you bend it, it's going to be a little more taut and that sort of stuff. So that's why it can maybe cause some swelling. By extension, you're pretty safe. So it's something to consider. I always tell people, if you can get the extension, that your journey just became so much easier. Yeah, you may have some tightness in the flexion, may have to bite the bullet like one session, but just get that extension and then the flexion will come again, unless unless the graft is put in a bad way, or you didn't try for 2 straight months and it's like
Yeah.
month 3 and you're like, oh, let's try and get your knee to bend. That would probably be an issue. But extension, you can go to town to a degree, but see what your patient's doing and everything like that. So unless you get someone again who comes in 20 degrees,
Yeah.
right off the bat, loss of extension, that's gonna be a little bit of a tougher journey.
Yeah, definitely. Let's transition to your much passionate topic you have, cyclops lesions.
Yes. So
Let's get revved up this early in the morning.
yeah. So I was listening to a podcast. Should I mention the podcast or
No, I don't think we need to mention
podcast
podcast
and
names.
names.
Just mention other people's viewpoints.
Yeah.
Which everyone's entitled to their viewpoint.
So some people believe that cyclops lesions are just kind of part of the process. That it was just like, it's a coin flip. You get it, you don't get it. I wholeheartedly, completely, utterly disagree with that concept. Been with doing ACLs since I've been in PT school, haven't had any cyclops lesions. Have had any needs for second procedures, which is awesome. And that's mostly because of what we do in the earlier stages. If you look at cyclops lesions in individuals who have them on MRIs, only 10% of them are truly symptomatic. So a lot of people have them, but it doesn't bother them, limit their range of motion. There's studies of individuals, if you don't get the range of motion within 3 weeks, it starts to spike up to like 2 or 3% chance of getting a cyclops lesion, a symptomatic cyclops lesion. If you don't get it after 6 weeks, it jumps up to 8%. Now what the studies or the percentages are afterwards. So yeah, I don't believe these are just something you just randomly draw a card of cyclops lesion and you're screwed with it. I think it's I don't want to say negligence on the therapist, but it's poor care to start off the rehab. You're not getting that full extension. So I think it should be rephrased or renamed into like lack of extension syndrome or something like that, causing anterior knee pain. I don't know if it's like, oh, we want to truly blame this cyclops lesion. And like they go in and let's say they have it symptomatic and they go and they clean it out. And then what do is they put you through aggressive rehab. So it's like they put you through 5 days of rehab afterwards, from my understanding. And then you're forced to get extension. They'll put you in a knee immobilizer and everything like that. So I start to even question, like, is it the second surgery that fixes these, or is it the aggressive rehab and forcing the individual to, hyperextension? So if you're dealing with cyclops lesions and that sort of stuff, you're probably going, this episode's for you. You're probably going too hard, too quick on some other things. And you're really hammered down getting full extension early on. If you're like, I have all my strategies, they're not working or anything like that, then humble plug, I highly recommend that you take this course. Next time. That's the only time I ever give a humble plug there. So, but again, I really think the MUAs don't need to happen. Secondary arthroscopic procedures, I think that's all, if that's the case, that's on the therapist, unless you really have a butcher of a surgeon.
Well,
go ahead.
I was just going to say, I won't put it all on therapists. Yeah, I mean, probably a large portion of it, because and we talked about this during the course too. We think most of the high re-tear rates, we're looking at 40 to 60% of re-tear rates, probably comes down to us as PTs. But what else goes into that? Is it, can we get the patient for prehab, right? That we talked about that being a big factor, because now we can educate the patient as well. So being able to educate the patient, are we educating the patient enough and frequently so they understand, like, this is a big deal, we need to really focus hard and often in the beginning? Do we get patients early enough after surgery? Sometimes we don't get the patient 1-2 weeks after, 2.5 weeks after surgery. Like, that's probably on a surgeon, right? Like, why aren't you sending your patient to PT the latest a week after surgery? I can understand maybe, you want to give it a day or two, but they should be in PT right away. So that's not necessarily onto us, but also when we get those patients that are 2 weeks behind coming to therapy, do we have the knowledge and skill set to understand what we need to go and do to prevent it, like you're saying? Yeah. So I just want to say that, like, we are hard on ourselves, as we should be, as therapists, but also understanding there are other variables as well.
I would say those definitely set the road nicer. And again, kind of like, let's say maybe half of our clients come in with pre-ab, the other half are this wide variety of anywhere from week 1 to 5-6 weeks out. And definitely they're more of a struggle when they're that far out, but there's still a chance for them. And that's the thing. I just tell them, it's like, this is going to be a little bit more uncomfortable road. I don't like to put in nocebo mentality, but when you see so many times and you see how it's tougher and you start playing with their joints and that sort of stuff, and it's, instead of it being, nice and easy to push down, it's firm and they're uncomfortable. They're changing, their body doesn't even know where their knee is. We now got some soft tissue, contractions of sorts, but even those, like, we're able to work with it. It's just, I'll tell them, I'm like, hey, we're getting you at week 5, we're getting you at week 6. Our window is now minimal. We have to go harder. And if this is too much for you, I completely understand. But we're going to do everything in our power. It's, the patient also has to take some accountability as well. Some of the ones that don't come in are sometimes the patients. We've had a couple people being we're in colleges and that sort of stuff. They get the surgery in the summer and then they're moving in. They got a lot going on. It's, first week, it's party week, yay. And then they don't show up for therapy for 2 weeks to start off, and they lost that window. So a lot of it's on the patient as well. I was talking about in the course, it's, patients need to be ready for surgery, and they express that, and they understand it's essentially a full-time job. Especially if they want to return to sport. If you don't want to return to sport, maybe it's not a full-time job. You do your therapy 3 times a week and do some stuff at home. But if you want to return to sport, especially at the high level, it needs to be a full-time job. You need to be going to therapy, multiple times per week, preventing any potential secondary issues. And then you be working out at home and that sort of stuff. So that's it too, is like, making sure the patient's on board and understands the expectations of them as well. So if they're going out and you get all the great extension stuff as you want, and then as soon as they walk outside the door, you see them walk away, they're starting to go with that bent knee, and then they come in the next day and they're like, lost 10 degrees of extension. I need to make sure they know, listen, we need to improve the way you walk.
Yeah. I want to talk about, we're talking about paying attention to the beginning details and timeline, but there's just understanding that we need to just not rush the whole process, right? And we talked about how Adrian Peterson set the bar too high. I think that was a quote from him that you had mentioned. And for a while it was accelerated programs, right? Even for most post-ops, accelerated programs for ACL, for shoulder surgery, things like that. And now, research and they're starting to realize, and surgeons are realizing, and probably why they're delaying PT is, they're understanding, like, the body still needs to heal. And when we're talking about specifically the ACL, right, that area needs to religamenticize. Is that, if I'm saying that correctly there? Religamentization is the correct term. For a graft. So, and that takes 1.5 to 2 years. I mean, you look at any high level athlete, they may return at the 9 or 10, 12-month mark, but they all say they don't feel normal until 1.5 to 2 years out, where they really start to get that explosiveness back. So we need to be able to educate our patients on the timeline that this is going to be. And I just had an eval yesterday, and the dad's like, "Oh, we need to get back by September." I was like, yeah, that's not going to happen. What's that? 7 months? Is my math right? Or 8 months, whatever it was. I was like,
March, or it's April, pretty much.
Yeah. So, and I was like, the stats go up significantly if we try and bring an athlete, especially a female, back before 9 months. I was like, so yeah, we can bring her back and she'll be back, but do you want to go through this again, or potentially go through this again in a year or two? And I'm not trying to fear monger, but your daughter's a freshman, she has a shot at playing D1 ball. Well, let's do this right the first time and not rush her back. Let's just get her back for next season, next spring, and we'll be good to go. By the fall, yeah, she'll be running and cutting and being able to do that stuff. I necessarily wouldn't, put her out in the field, especially as a middle infielder where you're, cutting and juking a lot more abrupt stops around the bases. You're in cleats, which is an uneven surface as well. Your cleat can get stuck around the bag, in a bag, sliding. Some of the fields aren't always the best, especially now you have turf fields that are out there. So, let's just do this right. So educating that patient, and I think that goes on us too. We try and oversell ourselves. Oh yeah, we'll get them back fast. We're really good with ACLs, right? We want to educate the patient that we're their best provider for them. Well, it's being the best provider for them is telling them, hey, we need to not rush this. I'm not going to guarantee you that your kid's coming back in 6 to 9 months. They'll be moving around, they'll be running and stuff. They're just not ready to go back to sport if we want to do this the right way. So I think we have that. And I think that leads to the beginning part, of us ramping through and blowing past that knee extension because we want to have that accelerated program and get them back in 9 months.
Because it's exciting. And the parent, I mean, every time we do something where it's somewhat related to sports, something advanced, that's when the parents' cell phones are like, they start doing it. They don't care about anything I did the last 2 months on the table, whatever it may be. Like, you don't get much pictures of that. Maybe every once in a while, how much knee flexion they have. I'm like, you should really take pictures of the extension, but that's fine. You do you. But I think that's again, it's like you said it so yourself. It's like almost like a sales pitch. It's like, oh yeah, we'll get them back into this sort of stuff. They won't even know in 3 months. I almost think the accelerated protocols and programs. Now I think of like research and all that sort of stuff was ulterior motives for like groups to say that okay, yeah, this group next to us, they take a year. We're doing it in 6 to 9 months. It's just like the quad sparing total knee replacement. I mean, the quads have been spared for ages. That they don't go through the quads. They deflect the quad with the patella, but they've been doing that for ages. But groups around us were started to name it quad sparing, and actually had worse outcomes than the traditional because they couldn't see the lateral aspect of the knee. So I think that if I look at it, I'm like, maybe that's what it was. It was like almost like a sales pitch, kind of got people in, and it wasn't until, unfortunately, not as many people know to go up and be like, all right, what are your outcomes? How many of your athletes return to sport? How many go with the pre-injury up to like, especially surgical, PT groups, whatever it may be. And maybe if we start asking more of that, we'll start finding the providers that really get the job done.
Yeah.
And a lot of it is, obviously you need a good surgery, you need someone on board, and that requires education to get the patient on board from day one. And then, good quality therapy. And then what you said is like looking at it from a regional standpoint. I mean, especially when they're on the table and they can't do that much, that's your opportunity to set the tone for so many things. Again, I'm looking 10 steps ahead. Yes, I need to do extension, but if they don't have that full ankle dorsiflexion, that's going to cause some issues when I get into jumping, running, cutting. So I'm going to do that while, they have a capacity to maybe lift their leg 10 times and then they're wiped out for 20 minutes. I'm going to work on some other things. So, think of it, think of the whole picture.
I'm actually working on something kind of in general for the clinic, but now, I'm going to even make this specific for ACLs. Like, we're transitioning to a digital world. We have all this technology and everybody's, all wants apps and things. Making pre-recorded video of the appropriate timelines. It doesn't have to be super long. It doesn't have to be super scientific, but that's something that they can, and as therapists, we all kind of hate after a while repeating ourselves and stuff like that. Hey, you're here icing for 10 minutes, watch this video, and you give it to them. It's a link they pull up on their phone. Everyone's on their phone anyway on ice, and they watch it, right? Make them watch it every session or once a week, or, email it to their parents. Like, other ways, let's use technology for other ways to educate our patients. One, is going to save us time. And two, the patient can go back and listen at any time. So, that's something I'm toying around with. I don't know if you have any other suggestions that you like to do with your patients as well, utilizing, technology. I know you like your gadgets, so
Yeah, I mean, we have definitely a lot of gadgets. Whether it's EMR or not EMR,
well, yeah, that too.
EMG. Yeah, I guess we do. Which helps facilitate things, but BFR and all those sort of things, and they're great. Um, they're obviously adjunctive to everything that we have to do. But yeah, I think that's a great idea. We have like some prehab stuff where it's like, here's a list of exercises. We'll take a look at you. Here's the ones based off of your current limitations that you should probably really focus on. Because I always say there's some people who they can really strain their knee and suck at bending. People can bend their knee and suck at straining, suck at both. Their programs are all gonna be different. I know some of the generic apps, there's some even ones for ACLs and that sort of stuff. It's generic, like it's here's a program for you first week, second week, but it's not specific to the patient. They're spending time,
Doing
doing
things that,
straightening and then bending exercises, and that bending's cooking, like causing a loss of their extension. Well, I need to be able to evolve and switch that. So I think always having someone to contact and have you understand what they're doing at that time is super beneficial. But yeah, I love the idea of phases. I'll write up battle plans, and I'll give sheets out of like laying out the first couple of weeks of what they should do, best strategies. I give one to the athlete, knowing that's probably gone, and one to the parents.
right.
Try to text them as well, like, or email it to them so they have an electronic copy. I mean, it's printed out.
Yeah.
And I'll write any little recommendation specifically. I'll just, here it is, and then this is what I want you to do, or highlight specific things. I'm like, this is for you. I think that's always a good idea, especially if you can get the parents on board, because
Yeah.
again, there's so much going on with them. Even the prehab when they're maybe not in too much pain, just it's a shock to the system. They have to prepare for this surgery, especially if it's high school. They know 5, 10, 20 people have gone through this. It's a long road. Their mind's in a million different places. Plus that and the classic ADD of most kids. So you get the parents on board, they can help out. And then they can always just reach out to us whenever they need to.
Yep. Awesome. Yeah. And anything else? I think kind of sums up the importance for today's topic. I mean, we can obviously go back and continue going. And we had a 2-day course that we're talking about this in 30, 40 minutes. So obviously there's a lot of detail, but I think the big thing is we need to stop rushing this. Understand the natural healing process and phase that need to go on, and not try to skipping ahead. To do the more fun stuff. And last thing, actually, you were talking about the gadgets, right? The gadgets are always fun, and PTs are the worst at this. We love the new shiny object syndrome, and you mentioned things like BFR or hop test measurements and things like that test RSI and things like that. Like you said, those are just adjuncts, and I think as PTs we think they're replacements. So that can bias us as well. Like there's nothing that's going to replace a keen eye and experience. Like we can try and make apps with algorithms that are going to hedge our bets, but the people are going to fall through the cracks on that. We need to be able to really still utilize our clinical decision making and rationale, and use technology as an asset to enhance what we're doing, not replace what we're doing. I just don't see artificial intelligence replacing what we're doing. It can only help what we're doing.
Especially from a psychology standpoint, just don't see any AIs being able to recognize when a person's checked out or emotionally traumatized and be able to cater your therapy to that. I think, we need to know our worth in the whole grand scheme of things, or kind of know our place. Yes, I'd love to see the ACL from prehab, or ideally I like to do like prevention stuff with teams, but prehab all the way through the whole thing to going out and seeing them play their sport. But I know, in these timelines where most of my worth is during those earlier stages. I can find an amazing performance coach to do probably better than what I can do in regards to exercise prescription, because that's what they do all day. Strength training, even performance metrics. I just hung out with a bunch of sports performance coaches in baseball, CJ, Shout out to him. And I thought I knew metrics of things. They're blowing my mind with that sort of stuff. So you can find someone, and it'll probably be more economical. Let's face it, we're a little bit more expensive than, going to a personal trainer or coach and that sort of stuff. But nobody's going to be able to implement those hands-on manual therapy, psychology benefits. I mean, they can get sports psychologists too. I've been known to implement that or have that as part of the team. But knowing where you can add the most value to this whole long journey, it's probably in very earlier stages, and understanding maybe those return to sport metrics as well. Ideally, see them through and through, but let's invest early on and get the ball rolling early.
Yeah. Great points. All good stuff, man.
Awesome.
Yeah, I think that's it for today. Unless you got any other words of wisdom, Jay, this is your wheelhouse, my man.
Yeah, so I know it's all good, all high level. We all have really good outcomes because we all think like this. And we're just trying to improve this, better than 55%, 60%. Hopefully we can get into the 90s for this procedure. And maybe invest the 9 months, year of your life into something. Hopefully you can come out with better outcomes. But hopefully tune in. I'm sure a lot more episodes can come from this weekend. But figure that's probably a good way to start off. So take your time. It's a long journey, and just make sure you get the earlier stages in.
Yeah. And sign up for the course. DM us if you have questions. That was supposed to be the only time we run this, but we are getting some, a lot of DMs asking if we're going to do it again this year. So if we get enough of you guys to request it, we'll try and squeeze it in on the second half of the year. If not, we're gonna have to wait till 2023. But yeah.
So hopefully if anybody wants to, even outside, me and Brandon do love to travel. So maybe even outside. Maybe
we'll come to your
private course. Yeah. Hopefully we can make this happen a second time. It was a blast the first time, and let's get those ACL outcomes 10 times better.
Okay. Cheers.
Cheers, everyone.